A very good morning to everyone who has managed to join. Thank you for making time to attend our 11th webinar series. Today, we'll be discussing beyond the standard lipid panel, insulin, C-Peptide, alipoproteins as biomarkers of metabolic syndrome. Our presenter today will be Kevin Nyangweso, who is the sales manager at Keton Consulting Limited. So we'll be able to start on time so that we are able to finish early, and I'll also be able to go through the Q&A session for any question that you may have. We'll be able to unmute the microphones at the end of the meeting. Should you have any concern during the meeting, you can kindly raise your hand, and we'll be able to address it. Otherwise, thank you for making time, and I hope we learn from this particular session. All right, so over to you, Kevin. Kindly share your screen and unmute your microphone, and we'll be able to start. Thank you.
Good morning, Ayub.
Proceed. Your screen is up, and we can hear you well. Good morning.
Okay, so good morning, everyone. My name is Kevin Nyangweso. Professionally, I'm a medical lab scientist, currently working as the in vitro diagnostic sales manager at Keton Consulting. So my presentation today will be based on metabolic syndrome and the biomarkers for metabolic syndrome. We want to look at the standard lipid panel, its limitations, and then the new metrics like insulin, C-Peptide, and the ApoA and ApoB. Why do we consider them more superior to the standard lipid panel? So I think we will go with that. So as part of our learning objectives, I think we need to understand what metabolic syndrome is and also explain the limitations of the current diagnostic criteria for MET-S. And then we need to differentiate the clinical utility of insulin and C-Peptide in assessing metabolic syndrome and also type 2 diabetes mellitus. And then we need to interpret apolipoprotein B to A1 ratio as a superior predictor of cardiovascular risk compared to the standard lipid metrics that we always do. And then we also need to understand how to apply this panel of advanced biomarkers to improve on our patient journeys and also to do more risk stratification for metabolic syndrome. So to define terms, what's a biomarker? What's metabolic syndrome? So from the word biomarker, from biology or biological state, and then a marker as an indicator or to show something. So a biomarker is a measurable variant that is used to indicate a given biological state or function. And then what is metabolic syndrome? Metabolic syndrome is also known as syndrome X or the insulin resistant syndrome. So these are a cluster of cardiovascular risk factors that co-occur. They occur concurrently and simultaneously within the same individual. We'll discuss them later on. And then now we understand that biomarkers for metabolic syndrome, they will help us to put more emphasis on precise diagnostic treatment so that we maximize the importance of these to our patients where we serve them. Okay, so Globally, metabolic syndrome is a growing public health challenge, and it constitutes, like I've mentioned, a series of events that are concurrently happening within the system. So this cluster of risk factors, they occur within the same individual simultaneously and within the same time. So the World Health Organization has approximated that 1/4 of the global population, or the global adult population, is affected by metabolic syndrome. And metabolic syndrome is a precursor of two global causes of mortality and morbidity, and that is the atherosclerotic cardiovascular disease and the type 2 diabetes mellitus. So studies have been done to demonstrate that individuals with metabolic syndrome have an increased risk for CVD and type 2 diabetes mellitus. So studies like the Framingham Heart Study and the Botnia study demonstrated that individuals with metabolic syndrome have got twofold increased risk for CVD. That is, if you have metabolic syndrome, you are 2 times more at risk for cardiovascular events. And then if you are having metabolic syndrome, you are 5 times more at risk for developing type 2 diabetes mellitus as compared to those without metabolic syndrome. So this cluster of cardiovascular risk factors, there are metabolic alterations that are associated with excess fat. So when you are having metabolic syndrome, there's a more lipogenesis occurring within the system. So with more lipogenesis, we would say that this occurs when your caloric intake is greater than your caloric expenditure. The amount of calories that you consume is more than the amount of calories that your body can spend. So these factors arise from, may cause insulin resistance. We have dyslipidemia or atherogenic dyslipidemia. We have elevated blood pressure and the apothrombotic and pro-inflammatory state. So with lipogenesis, there is more buildup of adipose tissue. And when the adipose tissue, when there's more buildup, we expect that there are more cytokines or the adipokines that are being produced. So adipokines like leptin, which is used to regulate long-term energy, and resistin that is linked to insulin resistance, they're produced more. So when we look at these adipokines being more in quantity in the blood, the pancreas now produces insulin, but then the cells that are supposed now to pick up this insulin to be used in now glucose regulation, they become resistant to the insulin. So glucose builds up in our system, causing hyperglycemia. So the current diagnostic framework that is used to diagnose metabolic syndrome has been developed by different organizations. And these organizations include the NCEP, which is the National Cholesterol Education Program for the Adult Treatment Panel, the International Diabetes Federation, the American Heart Association, and then the National Heart, Lung, and Blood Institute. So these organizations have come up with a criteria in which we evaluate and assess an individual to be having metabolic syndrome. Although these criteria have got minor variations, but the standards they give require that we have at least the presence of 3 out of 5 of the core components that they've highlighted. So the key component that these organizations have given us, or the criteria that they've given us to score somebody to be having metabolic syndrome. One, when somebody is having elevated waist circumference. We know that the standard waist circumference is 102 centimeters for males and 88 centimeters for females. But now if anybody is having a waist circumference of above this, according to the NSEP, we consider them to be having an elevated waist circumference. And then secondly, hypertension. Hypertension is elevated blood pressure. The normal blood pressure is supposed to be 120 and 80 for diastolic and systolic. But when the blood pressure elevates to 130 or 85, we consider this person to be having elevated blood pressure. So this is part of the criteria that we use to consider an individual to be having metabolic syndrome. And then hyperglycemia. We know that within all our labs, we consider a blood glucose of 3.5 to 5.5 millimoles per liter to be normal. But with metabolic syndrome, when the blood glucose is above 5.6, this is also a part of criteria to do risk stratification for metabolic syndrome. And then increased triglycerides and lower HDL. That is the high density lipoproteins. We know that the high density lipoproteins are also referred to as the good cholesterol. But then when it is decreased, now we start questioning the underlying effect of metabolic syndrome and also co-occurring with increased trig. Increased trig arises when we mentioned about lipogenesis. More triglycerides are in the system, but the system cannot consume or maybe transport the triglycerides out. So with a buildup of triglycerides in the system, there is dyslipidemia occurring, and this is a cofactor that is used to evaluate metabolic syndrome. So these organizations, they've given us a criteria to diagnose metabolic syndrome with various guidelines, though there are minor variations, but each organization has given us their guideline. For instance, when you look at waist circumference in centimeters, the National Cholesterol Education Program has given us 102 centimeters for males, a value of greater than this. Remember that these criteria are used currently. You can't use waist circumference alone to diagnose metabolic syndrome. What do? We look at the waist circumference plus the HDL in millimoles per liter plus triglycerides in millimoles per liter, or if you do it in mg per dl, whichever your biological reference interval says, together with fasting glucose and together with blood pressure. So an elevation in any three of these is considered to be an indication of metabolic syndrome. If there are two, we say no. If it's one, we say no. So this brings us to the challenge that if it's 3 of 5, what of a patient who is having 2 of them? What of a patient who is having only 1? Probably this patient is having normal trig, normal HDL, and normal waist circumference, but then the glucose is 7.5, for instance, millimoles per liter. What do? So this is part of the current problem that we have with this diagnostic framework. That yes, they require 3 of 5, but now it's either all or nothing. Like you either have the 3 for you to be diagnosed with metabolic syndrome, or if you have 2, we say you're not having metabolic syndrome. So The first problem is that the 305 approach is blunt. It's an all or nothing tool. That a patient with two severely abnormal criteria, probably high trig and low HDL, will not be diagnosed with metabolic syndrome. While a patient who is having 3 borderline, maybe a glucose of 5.4, a trig borderline and HDL borderline, will not be considered to be having metabolic syndrome. So this current diagnostic framework fails to capture the continuum risk. What do I mean by the continuum risk? We need to evaluate the individual pathophysiological risk of each of these parameters. We need to look at if it's elevated glucose, what's the individual risk? If it's elevated trig, what's the individual risk? If it's low HDL, what's the individual risk? So this criteria does not capture the individual risk for these criteria for scoring. And then secondly, most of the times when we do the standard lipid profile, our clinicians focus more on the LDL cholesterol. We know that the standard lipid profile contains trig, HDL, LDL, and total cholesterol. But in the diagnosis of cardiovascular risk or our lipid profiles, our clinicians focus more on LDL-C. But the focus now is on the components of LDL. We want to look at the more atherogenic particles. We want to look at, aside from LDL, what are the atherogenic particles in the very low density lipoproteins? What are the atherogenic particles in the intermediate density lipoproteins? What are the atherogenic particles in the low density lipoproteins? Remember, we have 3 components of LDL. We have very low density, we have intermediate density, and then the LDL. So all of these 3 contains a component that we call apolipoprotein B, which is now more atherogenic than the LDL itself. We now look at the component in the LDL, which is more precise in diagnosis. So a patient can have a normal LDL, but when we look at ApoB, which is present in the very low density lipoproteins, in the intermediate density lipoproteins, and the LDL, the ApoB could be elevated. So a patient may be having a normal LDL, but a very high number of these dangerous particles that we call ApoB or the apolipoprotein B. So when we are considering the risk using these standard metrics of 3 of 5, we may miss in just looking at LDL, trig, and HDL. So we need to shift focus to a more precise and a more accurate criteria. And then 3, as part of the current challenge with this diagnostic framework that of 3 of 5, we look at hyperglycemia or elevated fasting glucose. But then for glucose to be elevated, we look at the pancreatic beta cells that produce insulin, and then with insulin goes to the cells to initiate glycolysis. So with elevated fasting glucose, this is a sign of late sign of progression of insulin resistance. And also it's a sign that the beta cells in the pancreas or the islets of Langerhans have failed from time ago. So by the time we look at elevated fasting glucose, there's a lot of pathophysiological damage that has already happened. This one comes on later on. Probably this person started having challenges of insulin resistance from maybe 2 or 3 months ago. So by the time we are having elevated fasting glucose, this patient is having metabolic damage that has occurred. So we need to shift focus now from looking at just the fasting glucose and then the HbA1c, which was also elevated as a late stage process, because for HbA1c, you look at 3 months of elevated fasting glucose. So you want to wait for this patient to have elevated glucose for 3 months, and then that's when you want to diagnose that this patient is having hyperglycemia. So let's shift focus from the normal fasting or random glucose to now these precise biomarkers that are more effective and more precise. Okay? From our discussion now, I want us to look at a question here. And maybe type your responses in the chat box. Which of the following is the most significant limitation of using standard LDL cholesterol in patients with metabolic syndrome? We mentioned that. So maybe type in your responses in the chat box. A, it is too expensive to measure. B, it measures cholesterol mass, which can be normal even when the number of atherogenic particles is high. 3, it is not a component of any metabolic syndrome diagnostic criteria. And D, it's unaffected by statin therapy. So probably can type in your responses in the chat box to see if we are together. Okay, okay. Yes, so from the responses, people are saying B. Yes, it's correct, because we've mentioned that LDL cholesterol, it's measuring the cholesterol mass. But then our focus now is in the atherogenic particles, which we've mentioned to be the apolipoproteins. So the LDL can be normal, but then we have elevated number of these atherogenic particles. So that's part of the limitation of using the standard LDL cholesterol in patients with metabolic syndrome. So once we understand the challenges with the current diagnostic framework for metabolic syndrome, how do we move now to more superior criteria that will reveal now the pathophysiology more earlier, more directly, and with a greater precise and predictive power? So the current cluster that is provided by the International Diabetes Federation National Cholesterol Education Program, they are grouped as you must have either all the 3 or 5, or we don't consider you. But then we need to move from these late stage consequences to a mechanistic more understanding of the root cause. Like we've mentioned, when you look at glucose, it's more of a late stage consequences of the beta cells failure. And we now need to understand, when you look at the beta cells failure, what happens? What is the immediate what's the immediate physiology that occurs when these cells fail? Probably they won't produce insulin, or probably there will be overproduction of insulin. So what happens? Now we need to check, why do we consider C-Peptide and insulin as having more predictive power, as being more precise than elevated fasting glucose? Elevated fasting glucose is a late stage breakdown in a long running process. Like the patient could be having an issue with the pancreas, and we need to understand this process, the pathophysiological process, early enough to help us make an intervention for this patient as soon as possible. So C-Peptide and insulin, they conversely measure this breakdown in this pathophysiological process. So What does fasting glucose measure? Fasting glucose measures our average blood glucose after an 8 to 12-hour fast. It's an estimation of our glucose after having that fasting 8 hours or 8 hours to 12 hours. So our body is designed to maintain our glucose levels within a very narrow range. That is probably 3.5 to 5.5 millimoles per liter, around there, depending with the reference intervals that you use. So by the time our glucose is rising above 5.6, it shows that the pancreatic beta cells have been struggling for quite some time, probably months or years or even decades, with insulin resistance. So when I talk of insulin resistance, the cells that are supposed to be used for glycolysis, they develop resistance towards insulin, probably because of the disposition of the adipokines that are now circulating in the system with elevated caloric intake. So once we have this resistance, elevated glucose is the last component of this fall of our pathophysiological process. So waiting for glucose to be elevated so that we can now make an intervention is like waiting for your car engine to fill up before you check your oil. It's like waiting for the engine just to blow up completely before now you make an intervention for your car. Okay? And then for insulin and C-peptide, we now want to see how the body is responding to the insulin resistance. We both understand that in the biosynthesis of insulin and C-peptide, physiologically, they're both produced as one precursor. Insulin and C-peptide are produced by the beta cells of pancreas as pre-proinsulin. And then there's cleaving to proinsulin. And then from proinsulin, that's when we have a pathway for C-peptide and insulin. So they both have the same precursors, which can assist us to evaluate their secretion. So what do they measure? They measure the body's response to insulin resistance. So to keep the glucose, our system glucose normal in the face of insulin resistance, the pancreas will hypersecrete insulin. And so when we measure insulin with hyperinsulinemia, it will show us that there is hypersecretion and probably there is insulin resistance in the system. And then what about C-peptide? So both of them are measured, C-peptide and insulin, but we consider C-peptide being superior than insulin for a variety of clinical reasons. First, when you look at the half-life of C-peptide and insulin, we've both now understood that C-peptide and insulin both are precursors of pre-insulin. But then one is having a longer half-life, one is having a shorter half-life. The half-life of insulin is 3 to 5 minutes, while the half-life of C-peptide is 20 to 30 minutes. So with this longer half-life, C-peptide levels in the blood are much more stable and representative of the average insulin secretion. And again, insulin is easily affected by external sources. Probably somebody is having medications or injections. So this can lead to alterations or false elevation in insulin levels. But when we look at C-peptide, it's not easily affected by external sources. I know somebody will ask me, if insulin is having a half-life of 3 to 5 minutes and C-peptide a half-life of 20 to 30 minutes, how are we able to do the analysis? How are we able to collect the sample and measure? So with a half-life of 3 to 5 minutes and 20 to 30 minutes respectively, once you collect that sample and centrifuge and centrifuge your plasma from the cells, or your serum from the cells, sorry, the physiological processes stop. So the insulin that is in your sample is kept within the same level. So you can now do your measurement and see if by the time of sample collection, if it was elevated or not. So, and also we look at hepatic extraction. We know that all of them are cleared by the liver, but about 50 to 80% of insulin is cleared fast through the liver. So making the peripheral insulin levels to be a poor reflection. But then C-peptide is not cleared as faster, in as much as both of them are cleared, but the peripheral circulation of C-peptide is an accurate mirror of the beta cell function. And then with direct correlation to insulin resistance, you see elevated C-peptide is a proxy of hyperinsulinemia. Though we would say that insulin is a direct reflection, but there are several factors that we've mentioned that affect the insulin levels in peripheral circulation. So with the elevated fasting C-peptide, that's a direct correlation of insulin resistance. And then what's the clinical implication of both of these two? So a patient with a normal fasting glucose but high C-peptide level is insulin resistance. And this can be identified as soon as now it arises. So with this early identification, we can allow for early intervention now before we now start preserving the beta cell function. We can now try to do lifestyle changes or minor medications like metformins so that we prevent progression to diabetes and the cardiovascular complications that always occur after years or months, okay? So we've mentioned that insulin is having a shorter half-life and undergoes significant clearance by the liver. So peripheral insulin levels vary significantly. So also we've mentioned that both insulin and C-peptide they have what do we call? They have the same biosynthetic pathway. So the precursor of proinsulin can cross-react with can cross-react with insulin itself. So this one can lead to inaccuracies during measurement. What of C-peptide as a marker for now making an intervention? C-peptide is having a longer shelf life and it undergoes slightly lower hepatic extraction. So when you collect a sample, it would give us a true mirror of the pancreatic insulin secretion. So we consider both of them as gold standard biomarkers, but if you want a more precise, we would consider that you go for C-peptide. So like we've mentioned, the elevated C-peptide levels are not merely a marker of metabolic dysfunction. They are used independently. And studies have shown that high C-peptide levels indicate a risk of future cardiovascular events. Studies have shown, like the Women Health study, that the highest quartile of C-peptide, if you have an elevated C-peptide levels to the highest quartile, you have an increased risk for coronary heart disease compared to the lowest quartile. And then the Malmo Preventive Project found that C-peptide is a stronger predictor of a coronary artery disease, and total mortality in the middle-aged men. So beyond cardiovascular disease, C-peptide is associated with increased risk also for certain cancers. Now, if you want to look at pancreatic cancers, we always look at maybe CA19-9, but in certain scenarios, C-peptide levels, when they are elevated, they can also be used to indicate these cancers. So that is also one benefit. So there's also another question here. Why do we consider C-peptide a superior biomarker to insulin in assessing endogenous insulin secretion? Why is C-peptide considered a superior biomarker to insulin for assessing endogenous insulin secretion? We've mentioned, so the choices that we have, it's more directly involved in glucose uptake. It has a shorter half-life, providing more accurate snapshot. It is not significantly cleared by the liver and has a longer half-life. It is less expensive to measure in most laboratories. So probably you can keep your responses in the chat box. Yes, the responses that we have is C. So it's not significantly cleared by the liver and is having a longer half-life. So in evaluation of endogenous insulin secretion, and when we want to evaluate insulin resistance, C-peptide is a better biomarker, or is a superior biomarker. Now let's move to apolipoproteins, and we want to look at the atherogenic risk in metabolic syndrome. We want to look at these atherogenic particles. When we talk of apolipoproteins, these are the particles that have higher predictive value. We know that the standard lipid panel, which we do, has got LDL, HDL, triglycerides, and total cholesterol. And in our evaluation, it provides an incomplete and sometimes misleading picture in evaluation of cardiovascular risk, especially in the context of metabolic syndrome, where we only look at triglycerides and HDL. Sorry. So let's look at LDL cholesterol. What does LDL cholesterol measure? LDL measures the mass of cholesterol inside the low-density lipoprotein particles. We look at the mass. I want you to understand that clearly. The mass of cholesterol inside the low-density lipoprotein particles. But then, in metabolic syndrome, the lipid profile shifts. Somebody might be having a normal or borderline LDL cholesterol, but then the small atherogenic particles, or the small dense LDL particles, which are more atherogenic and they are prone to oxidation, can be elevated. And these ones easily penetrate the arterial wall. So when we look at these, when the atherogenic particles can easily penetrate the arterial wall, there is a higher risk of cardiovascular events occurring. Okay? There's an analogy here. You have two bags of marbles, or two bags containing stones, let's say so. So bag A is having few but large. Okay? but bag B is having very many but small. So this very many but small, the weight is definitely the same. When we measure the mass of cholesterol, when we want to measure LDL, for both of them, because we are measuring the mass, all of them are the same. But then the one with smaller particles can easily penetrate, okay? So with the second one, the risk of causing damage is higher. So when we measure these particles in itself, the smaller particles that are now in this LDL, it provides a better risk than the total weight of the cholesterol that the LDL carry. I don't know if I'm making sense, but our interest is now in the particles, the atherogenic particles inside the LDL, not the mass of LDL itself, okay? So these particles, what do we call them? These particles, we call them apolipoprotein B or ApoB. So these are the particles that are responsible for all the proatherogenic activities, okay? So these particles, they are not only present in LDL, like I mentioned earlier, they're also present in very low density lipoproteins, and also we have intermediate density lipoproteins, okay? And then we also have lipoprotein A, but this one is a component of also lipoprotein A. ApoB is also present in lipoprotein A, also called LPA. We'll look at apolipoprotein A and lipoprotein A. So our interest is majorly on these atherogenic particles, okay? So the plasma concentration or the serum concentration when we do our measurement of ApoB will give us the total number of the atherogenic particles, rather than measuring the LDL cholesterol, which is just the total mass of cholesterol in LDL, okay? So this makes ApoB a more direct, precise, and integrative measure of the central drivers of atherosclerosis. So in the context of metabolic syndrome, where the standard lipid profile is characterized by an increase in trig, lipoproteins provide a more sensitive, proves to be a more sensitive risk marker than LDL, okay? So there's one molecule of ApoB in every low density, intermediate, LDL, and LPA. So you can picture this. If you only measure LDL alone, you're leaving out the atherogenic particles in VLDL, IDL, and LPA. If you measure LDL alone, your focus has now left the very low density lipoproteins aside. You didn't look at them. You didn't look at the intermediate density lipoproteins, and then you didn't also look at the lipoprotein A. So when you measure ApoB, you look at the total number of atherogenic particles, which now encompasses everything in very low density lipoprotein, intermediate density lipoproteins, low density lipoproteins, and lipoprotein A. So it's a more precise predictor of the risk of cardiovascular events occurring. So in metabolic syndrome, where trig-rich lipoproteins are often elevated, ApoB provides a more accurate and comprehensive assessment of the atherogenic risk than the LDL-C alone. So we need to shift focus from only LDL-C alone to VLDL, IDL, and LDL, all of them, so that we understand more precisely the context or the pathological processes that occur. So studies have also shown that ApoB are a superior predictor of cardiovascular events than LDL. Like I've mentioned, yes, LDL could be a predictor, but it's too huge. And it's also not precise to what we want to look at. We want to look at these atherogenic particles. What's the risk of a cardiovascular event occurring? So studies like the InterHeart study have shown that ApoB is a more superior and precise predictor. Okay, so that is just an image that shows ApoB is better than LDL-C. So there's also another question here. ApoB measurement is considered integrative because I think we can also answer this in the chat box. Why do we consider ApoB a more integrative predictor? So somebody is saying A, somebody is saying B. But then we've mentioned that we want to measure the pro-atherogenic particles that are in our system. So ApoB does not combine the measurement of LDL and HDL. ApoB is a component of LDL only. We've mentioned that ApoB is a component of LDL, very low density lipoproteins, and intermediate density lipoproteins. So if you say that it's also a component of HDL, that's wrong. For HDL, we look at ApoA as being part of that good cholesterol. But for ApoB, its measurement represents the total number of all the atherogenic particles that can lead to the risk of cardiovascular events occurring. So that is where our focus now is. We shift focus now from the LDL-C measurement and now move to the apolipoprotein B. Okay? So I think that one now rectifies whoever said the choice is A. Now, let's look at now the ApoA that this guy has mentioned about HDL. So apolipoprotein A1, is the major component of HDL. And it plays a very crucial role in reverse cholesterol transport pathway. So in the cholesterol transport pathway, we know that HDL is the one that is used to transport the cholesterol away from our bloodstream. So this HDL, the major component that we have is ApoA1. So if it's transporting cholesterol away from our bloodstream, its functional is now anti-atherogenic. It provides that protective capacity. So HDL also measures the mass of cholesterol, but then when we want to now look at our protective capacity, we now shift focus to apolipoprotein A. So the higher the ApoA1, the better for us, okay? And then the higher the apolipoprotein B, the more risky it is. So ApoA1 provides a more reliable index of HDL particle number and function. So if you want to look at now the HDL in terms of its number and the functionality, look at now the component of that HDL, which is now apolipoprotein A1, which is now the major protein that is used in reverse cholesterol transport. Now we look at a ratio, and this is now where it now becomes more interesting. In the standard lipid profile, most of us do report LDL, HDL ratio. But from the discussion that we've mentioned, LDL and HDL are not more precise predictors. Now we need to shift focus on ApoB, ApoA1 ratio. Like we've mentioned, ApoB is the component of LDL. ApoA1 is the component of HDL. Now, from this ratio, okay, how do we now come up with a good predictor or a good risk indicator for risk stratification for a risk of cardiovascular event? So we've mentioned that ApoA1 is the major protein of HDL, which is the good cholesterol, and it's a direct measure of the body's reverse cholesterol transport. Now, why do we consider ApoB to ApoA1 ratio more superior to the standard LDL-HDL ratio? So this ratio will show us the balance between the pro-atherogenic forces and the anti-atherogenic forces. So ApoB is responsible for the pro-atherogenic activities. ApoA1 is responsible for anti-atherogenic activities. So we want to look at the balance. What's the balance of risk? Okay. So we consider this a more powerful and physiologically rational risk indicator than the LDL-HDL ratio. So it provides a single number. And in our labs, we've always said a ratio of less than 1 is considered to be okay. But when the ratio is above 1, that is now quite risky. So we need to now shift and now look at what is the ratio of the pro-atherogenic activities to the anti-atherogenic activities. So what's the clinical implication now from our discussion? A patient may have a normal standard lipid panel, but a high ApoB, ApoA1 ratio. Like we've mentioned, the LDL might be normal, but ApoB is elevated. HDL normal, but low ApoA1. So this one uncovers the hidden significant risk for atherogenic activities that would otherwise be missed when you just focus on the standard lipid panel. So this one also allows for earlier and a more focused or more patient-focused management. So the true power of these biomarkers is revealed when they're used together, so that we create a pathophysiological profile of a patient. When we want to look at the risk of type 2 diabetes mellitus, the risk of cardiovascular events occurring, we now need to use these biomarkers together. We now need to look into insulin, we look into C-Peptide, we look into ApoB, we look into ApoA1, and even the ApoB, ApoA1 ratio. Okay? So with this now, we are going to refine the risk of assessment for atherogenic activities. Okay? So these are just studies that have been done to confirm that ApoB, ApoA1 ratio are a superior predictor to when we look at the standard LDL-HDL ratio. So like the INTERHEART study identified that the ApoB, ApoA1 ratio is the most potent lipid risk factor for acute myocardial infarction. And with the risk in smoking being more higher, okay? And then the AMORI study, that is the apolipoprotein related mortality risk study, followed up over 175,000 individuals and found out that ApoB ApoA1 ratio was a strong predictor for fatal myocardial infarction, even in individuals where LDL-C levels were considered to be low. So now this one now shows you the LDL-C might be low, but when we want to evaluate the risk of cardiovascular events like myocardial infarction, ApoB ApoA1 ratio proves to be a strong predictor. Okay? And also, meta-analysis from emerging risk factors collaboration confirmed that ApoB and ApoA1 ratio are more strongly associated with coronary heart disease than LDL and HDL were associated. So, if you want also to look at coronary heart disease, ApoB and ApoA1 ratio are more strong predictors than the standard LDL and HDL. So, the point is, we need to shift focus from the standard LDL HDL ratio and change to the atherogenic activities. Let's look into the small tiny components in it. What causes these activities? Let's shift focus to ApoB and ApoA1 ratio. Now that we've shown that these two are a strong predictor for these activities. This is just a graph from the InterHeart study that shows that the risk on the y-axis vis-a-vis the ratio. So, as the ApoB ApoA1 ratio increases, the risk of cardiovascular events occurring also goes high. And this one was for myocardial infarction. So, when the ApoB ApoA1 ratio increases, for instance, at 1.28, the risk of having myocardial infarction also goes high. Okay? So, one question from our discussion. The ApoB ApoA1 ratio is a powerful predictor of cardiovascular risk because I think we need to also put our responses in the chat box to see. Is it a direct measure of liver function? Replaces the need of a fasting blood sample? Reflects the balance between proatherogenic and anti-atherogenic forces? Is exclusively elevated in patients with diabetes? So maybe you can put in your responses in the chat box. Yes, most responses are saying C. It reflects the balance between the proatherogenic activities and the anti-atherogenic forces. So when we want to look at the balance of risk, we need to shift focus to the ApoB ApoA1 ratio. So I also have one case study here. This is from a lab. A 50-year-old male with metabolic syndrome, that is a central obesity, hypertension, and a fasting glucose of 5.6. But then his standard lipid panel shows total cholesterol of 5.15, LDL of 2.07, which is considered optimal, HDL of 1.37, also considered optimal, trig of 4.19, which is borderline. So, based on his LDL cholesterol, the risk for any cardiovascular events appears low. However, the clinician requests for an advanced lipid panel with ApoB of 120. The reference ranges for this lab for ApoB is 60 to 117 milligrams per DL. So at 120 milligrams per DL, this is considered high. And then for ApoA1 is 90 milligrams per DL. The reference range for ApoA1 for this lab is 108 to 221 milligrams per DL. So with an ApoA1 of 90, that is considered low. So when you do a ratio, an ApoB ApoA1 ratio is 1.33. So these are very high risk for cardiovascular events occurring. But you see, this is now missed by the LDL HDL ratio that we have here, because they are all considered normal. So from this case study, we can just see that there's a high burden of atherogenic particles and deficient protective activity, because high burden from ApoB, which is elevated, and protective activities from ApoA, which is now reduced. So this one identifies a significant hidden risk that now warrants now an aggressive lipid lowering therapy. Maybe the patient needs to be started on statins, but now that is now for the clinicians to decide. So such kind of scenarios are quite common in our clinical practice. You find normal lipid profiles, but when you go into ApoB and ApoA1 ratio, it reveals an underlying risk. So this one now underscores the inadequacy of relying on LDL-C alone. So we need to shift focus from just the standard LDL and lipid profiles now to look at now the pro-atherogenic particles and anti-atherogenic particles, like we've mentioned now. So as Keton Consulting, I know most labs do not have the capacity to do this, to analyze these biomarkers, like the insulin and C-Peptide or the ApoB, ApoA1 ratio. Keton Consulting has got analyzers that now can support you. And these are analyzers that have been verified for accuracy, verified for precision, and verified for everything, including linearity. Like for ApoB, ApoA1, we have the bioassays 240 clinical chemistry analyzer and the Maglumi series for immunoassay. I think I would invite Ayub to now proceed to at least take us through the Keton portfolio. Ayub. Okay. So,
Hello?
yes. I wanted you to take us through the Keton portfolio.
Just finalize, or you'll be able to scroll.
Yeah, I'll be able to scroll.
Okay, so offering on the bioassay 240 plus. So this is a standard from mid-range, and we are also offering for high range and can work well as a backup analyzer or a primary analyzer in your facilities. So the 240 plus does 240 tests in an hour, so it's quite a high throughput. We have automated washer for the cuvettes, so no need of replacing the cuvettes. We usually have it replaced during scheduled intervals, about 3 to 6 months. The washer unit has the 4 needle wash positions that ensures correct cleaning and avoids carryover or cross-contamination of the sample. We have a wide range test menu and you can see on the lipids test menu, you can see all the parameters that we have discussed from ApoE, ApoA1, ApoB, homocysteine also form part of the portfolio, and yearly more tests are also being added to the analyzer. So it's a small unit benchtop that has a very powerful position in the market. Accuracy, precision, linearity, carryover studies have already been conducted, and they are quite accurate. We have the higher unit now, which is the C8 for high throughput laboratories that can do over 1,000 samples in 1 hour. The other unit is the Maglumi series. So we also offer Maglumi series from small range 600 to 800 to high throughputs, the X3s and X8s. This one will be able to analyze your insulin, C-peptides, and within 17 minutes, you have your TATs for these profiles. So the offering that is currently there, that's the X3, and that one particularly handles over 200 samples in an hour with over 20 positions for sample and 72 positions for your sample analysis. So in case you have any queries regarding our equipment offerings, you can always reach out. We have the reagents and also the analyzers.
Okay, so like we've mentioned, now we need to shift to biomarker guided treatment and also in monitoring progress. Okay. So in case you want to reach Keton Consulting, our offices are at Azina Circle Place, second floor. You can also email us at sales@ketonconsulting.com and also info@ketonconsulting.com. So at this point, I would now like to welcome any question that you may have. You can raise your hand or you can type them in the chat box. If you raise your hand, Haroun will be able to unmute you.
Okay, thank you. Mr. Kevin, for the powerful presentation. I hope everyone has benefited, and we'll dive into the Q&A session. We have Mr. Victor Goro, who had raised a question. Are there some considerations before suspecting or diagnosing METS? After how many times do we need to confirm the 3 to 5 approach? HTN, DM, TG, and HDL results depend on some factors. Kevin, so I'll be able to unmute, and if Victor needs to add more or expound more, we'll be able to sort that one out. So let me just.
So for Victor, maybe if I understood him correctly, the current diagnostic framework does not indicate how many times does the patient need to have an elevated waist circumference or hyperglycemia to score that this patient is having metabolic syndrome. Like we mentioned, the moment that you have any three of five of these characteristics, we cluster you as somebody to be having metabolic syndrome. So the moment that you have hyperglycemia, high blood pressure, elevated waist circumference, elevated trig, and low HDL, we say that this person is having metabolic syndrome. But when we move now to this biomarker guided treatment, once you realize that this patient is having an elevated insulin or elevated C-peptide, you move now to making that intervention directly, because you've now moved from a more general approach to a biomarker guided treatment. So if you realize that now insulin is elevated or C-peptide is elevated, you now move your intervention now to managing the insulin levels. If it's now from the pancreas, you check if it's from the pancreas, or if it's from the resistance is now from the elevated caloric activities, you now move your intervention to maybe a lifestyle intervention or now the statins. So there is a limited data on whether you can do subsequent testing before you enroll this patient to be having metabolic syndrome. But with biomarker guided treatment, you just shift your focus to the biomarkers.
Thank you, Kevin, for that response. So there's a question from Rahab Kamau. Why is HB1C not also considered as a biomarker for metabolic syndrome?
So with the diagnosis for metabolic syndrome, I mentioned this earlier. We want to, when you evaluate HB1C, HB1C is as a result of hyperglycemia that occurs after 3 months of subsequent elevated glucose. So HB1C is your average blood glucose in the last 3 months. In the evaluation of metabolic syndrome, we look at hyperglycemia plus the other class of activities that occur concurrently. So instead of evaluating HB1C, we evaluate the blood fasting glucose levels. But we mentioned that instead of using fasting glucose, let's look at now the pathophysiology of what is causing the elevated glucose, so that we make our intervention from as early as possible to reduce the risk of diabetes mellitus, type 2 diabetes mellitus in the patient. And that is why we've advised that instead of now waiting for glucose to be 8 or 10, shift focus now to, aside from the fasting glucose, check what's the patient's insulin or C-peptide levels. This one will provide you with a more faster diagnostic criteria so that you manage this patient before the patient slips from just having an elevated insulin now to having an elevated glucose to elevated HB1C to elevate now to type 2 diabetes mellitus. Before this series of activities occur, evaluate the risk from the beginning so that you make an intervention from the beginning.
Thank you,
So
Kevin.
nimejua the best ni nini, insulin na C-peptide.
Come again?
Unaona sasa, angalau sasa unajua unachapa insulin, C-peptide na apolipoprotein kama B. Hapo si unajua mambo yake iko aje.
Okay, I think that one was unmuted by mistake. So if you have a query, kindly raise your hand and I'll be able to unmute you. We have no query on the Q&A or the chat box.
In the chat box, Haroun, Stella Maris asked if we do offer placement services for our machines. I think maybe she can drop an email so that you can make a follow-up communication to her, right?
Yeah, sure.
Stella, you can just send a mail to info@ketonconsulting.com or sales@ketonconsulting.com, and then we'll be able to respond to your query on placement services so that we also understand which machine that you have. But that's an available program. Okay.
Okay. Vincent, how long does it take to upload CPD points? It will take between 1 or 2 days, depending on verification of the attendees. All right, Kevin, no other question on the chat box or on the Q&A. Thank you for taking us through that powerful presentation. That is very important We look forward to more. We have come to an end to our presentation for today. Once the CPD points are updated or uploaded, notification will be sent to the webinar group, as well as the slides for reference. We will also share the video or the webinar YouTube presentation so that you can be able to review at your own time on our YouTube page. Thank you so much for making time and attending. I wish you a lovely day ahead. Thank you. Victor, the link is put on chat box. You can click on it to join. Thank you, Dennis, for the feedback. Thank you, Moses, for the feedback. And thank you, Bincy, as well as Godfrey and Emmanuel. So feel free to join our WhatsApp group using the link. That is where we post our webinar updates and any other communications. That is our official line for webinar communications. Thank you. All right. Having no any other business, we'll be able to end the event. You can be able to leave at your own pleasure. The webinar will close at exactly 8:30. If you have any other follow-up query, you can always just put it on chat within the next 13 minutes and we can address